maybe just let me know when you've hit record.
I have. You're good to go.
Perfect. Well, good afternoon and welcome back for those of you who have attended previous Wednesday noon sessions. I'm Elizabeth Reinald, and we've been talking for the last 3 weeks now about topics specific to practicing in the personal care home setting. So I'll again mention that the Planning Committee has no conflicts to disclose, but specifically this week I am going to be talking about medication classes and specific medication. So I want to mention that I have no relationship with pharmaceutical companies and specifically have not accepted any honoraria. And I will try my best to use generic names. All right. Perfect. So the sessions have to a certain degree been building off one another, particularly building on the first week when we introduced the clinical frailty scale. So for any of you who feel like you missed that information, there's a YouTube available that summarizes. So I'm going to be building on some of the information about the clinical frailty scale. And next week, we're going to be talking about chronic care in personal care homes during COVID-19. And today we are talking about symptom management and palliative care for symptomatic residents testing positive for COVID-19 in the personal care home setting. So the learning objectives are perhaps a little more specific today. Jocelyn's put in the chat that we are going to be using the Mentimeter audience participation, so you can vote and participate in the quiz questions. So that's going to be www.menti.com, code 708530. So we got a little bit of a pre-test, but by the end of the session, I'm hoping that you'll be able to describe 2 reported presentations for residents with an increased risk of dying after testing positive for COVID-19, match the indication to specific classes of medications appearing on COVID-19 symptom management summaries across Canada, name a starting dose of hydromorphone for symptom management of respiratory distress due to COVID-19 in residents naive to opioids and how this would be different if people are on a stable dose of opioids. Describe the usual palliative dose escalation for opioids and then anticipate how this might be different for people with the high acuity respiratory distress form of COVID-19. And then to think about your pharmacy support in your personal care home and as a specific example, if there happens to be a drug shortage for one particular medication. So this is our first audience participation. I know if you're watching this on your phone, it may be tricky. You may not be able to participate. For others who may be on a different site using 2 devices, if you want to pull out your phone. And I think maybe somebody was briefly unmuted. So if you go to menti.com and enter the code 708530, it'll bring up all the slides, but also these participation ones. So the first participation is what classes of medications are listed on the PMH, palliative care standing orders for personal care home and transitional care. So that's PMH MSO 021, and we've got some people who are technologically savvy who have been able to participate in that already. So either you guys are going with the crowd or are familiar with the standing order set, but the crowd has it that in fact, spoiler alert, all of these classes of medications are on our palliative care standing order set here in PMH. So more of you are welcome to join. We're just going to move on in the interest of time. So how helpful are these drug classes for the symptoms described? So I've got 5 different drug classes and 5 symptoms. So for antipsychotics, how helpful are they for nausea? How helpful are opioids for dyspnea, benzodiazepines for delirium? I know it's a little fiddly with all those slides, but we've got from strongly disagree to strongly agree. How helpful are anticholinergics for dyspnea and benzodiazepines for anxiety? So I'll let you fiddle around with that for just a few moments here. And I think this is actually sort of an interesting, because it combines sort of what we're told in the literature and then your clinical experience. So I'll just give it a minute for a few people to be able to participate. And then I'll mention that we're going to repeat this at the end as sort of a post-test just to see. I like how this this format sort of gives the waves of how people are responding. All right, we're going to move on. And I'm going to start again with describing a couple of cases. So case 1 is Mr. G, and he's becoming short of breath. Mr. G is residing at a personal care home. He was tested for COVID-19 as a contact when his roommate tested positive for COVID-19. Mr. G's test result returned 4 days ago and is positive. Earlier today, he was alert, ate a good breakfast, did some stretching and balance exercises in his room. He has been watching TV. It's now mid-afternoon and he's coughing and dyspneic, and he has a slight look of panic. And he and his family have indicated he wants to be as comfortable as possible should he become symptomatic from COVID-19. And this conversation was updated when his positive test came back as part of a serious illness conversation. And we discussed that in some detail last week. The other case is Mr. M, and he's sort of fading since his COVID-19 test came back. Mr. M is Mr. G's recent roommate. He's now been COVID-19 positive for 6 days. 2 weeks prior to testing positive for COVID, he would putter around the personal care home, was requiring hands-on assistance to eat, or he ate with his fingers. He was fully dependent for toileting and received hands-on assistance for bathing, dressing, and toileting. He's had a diagnosis of Alzheimer's disease for 9 years and is in the severe stage of his Alzheimer's disease with non-word verbal utterances. So a bit hard to understand what he's trying to say, and he is therefore also severely frail. A bit more about Mr. M. In the first couple of days after testing positive for COVID, it was difficult to keep Mr. M in his room. He was diagnosed early in the outbreak and was quickly cohorted away from residents who had not tested positive. And he likes to wander and experience his world by touching things. 3 days after testing positive, he wasn't coming out of his room anymore, and he was requiring assistance to get from bed to his recliner chair. He was being brought beverages and encouraged to drink every time anyone went into the room and on his 1-hour checks, because he wasn't initiating drinking anymore. And by day 5, he was just sipping supplements or water and was mostly dozing in his chair when he wasn't asleep in bed. So I'm very grateful that I have no firsthand experience treating COVID-19, and hope that in our region, none of us end up with any experience. These are 2 potential presentations that were described to me firsthand by Dr. Benoit Robert, who's an attending and medical director at a large PCH in Ontario. And he and his site have been working through a significant outbreak. They had 21 cases and 11 deaths as of day 37 of their outbreak. And I'm very happy to report that their outbreak has now ended. They haven't had any new cases. But Mr. G and Mr. M are not real specific patients. They're based on Dr. Robert's description of the 2 main palliative presentations of COVID-19 that he saw. And this is consistent with reports that I've been hearing elsewhere of residents who died. So he noted that the bulk of their cases were in their specialized dementia care unit. And so we have to recognize that his experience is in a specific patient population. So people with underlying dementia, and maybe different in some ways from the general other reports, but this is certainly a common patient population in our personal care homes. So I think it is generalizable to our work. He noted that 2/3 of the people who died from COVID in their outbreak had the more typical quiet death of the very frail and end-stage dementia, and that would be as described with the case of Mr. M. And 1/3 had this rapidly progressive respiratory distress with dramatic air hunger, the high acuity presentation, and this would be the description of Mr. G. So this is going to just be a little bit of reinforcing some of the teaching from the last couple weeks. If you had to describe the two presentations, that first presentation could be called the low acuity presentation of COVID-19 in Dr. Robert's experience, personal care home dementia population. And the 1/3 are the high acuity presentation, the intense respiratory distress. And so our little frailty pearl here is, I told you about Mr. M and how frail he was 2 weeks before his COVID test was done. I didn't provide the information about specifically how frail Mr. G is, because in the high acuity presentations of illnesses overall, it seems that frailty is not as significant a predictor of death as it is with low acuity presentations, in which cases frail people have a higher mortality rate. And last week I told you about a recently released study from Pollack et al., where these were people presenting with non-COVID to the emergency department, and the high acuity, the frailty was not as good a predictor of mortality as it was for low acuity presentations. And then every time I tried to finalize this presentation, there was some other resource coming across my screen, and Miles et al. Just published a outcomes of 70 years of age and older people in London, England, and they actually looked at their frailty and said that frailty was not a good discriminator of prognosis in COVID-19 for people admitted to hospital. Now, the thing that this is my interpretation because this is just newly released, but if you're presenting to hospital, could we then say you have a high acuity enough presentation that you are seeking help from hospital and can't be managed in the community or in your personal care homes? So this is early days in COVID specific, but this was recently published, and sort of the title was that frailty was not helpful, which is significant because, as I mentioned last week, it's in the National Health Services triaging of people for intensive care treatment in the UK. So we're going to focus on the clinical management of COVID-19 today. And before we shift our focus to sort of comfort and palliative care, we're just going to sort of talk about some of those immediate considerations and people who want some trial of active management. So right after the COVID test comes back positive, it is important to update so with the disclosure of the positive status to the resident, if appropriate, and their substitute decision maker, it is a time to have the serious illness conversation, or at least one of the serious illness conversations about the COVID positive status, and update those goals of care based on what at that moment can be offered and the presentation. I have received or seen a number of order sets across the country through the Canadian Geriatric Society COVID Working Group. They actually sought out different order sets from across the country, and there are some common themes. So encouraging oral hydration and caloric intake is a priority. And I'm very excited to say that in PMH, we're actually working and fast tracking a nutrition and hydration policy, which we've been thinking we need for a long time. But now, because of the lens we're looking at the world, and since COVID, we are going to specifically be talking about people who are at increased risk of dehydration and malnutrition because they are in isolation and during cohorting. So I hope that shortly you'll be able to refer to this as supporting hydration and caloric intake in people with COVID-19. In addition, treating fever is often an early priority. Now, older adults and PCH residents may not have as frequent fever, but for those who do, that's something that can be uncomfortable. And often we say for frail older adults, maybe don't push the 4-gram maximum. That's more in the context of ongoing scheduled use for arthritis or other chronic pain management. If this person is symptomatic with COVID-19, bringing down their temperature, using that 4 grams for the period when their active management is needed is reasonable. And then you could reassess it for bringing it down closer to 3 to 3.5 grams in 24 hour. And then often there's a suggestion to order titrate oxygen for O2. And the orders that I've seen kind of differ from above 90 to 92 to 96. And many of them contain a comment about using a maximum of 5 liters. In the acute care and emerge setting, they're not considering higher flow oxygen as an aerosol generating medical procedure. But Dr. Robert's observation is also that if there's a small increase in the risk of staff and other people in the environment and spreading the virus, the benefits, the incremental benefit with oxygen more than 5 liters, he didn't say that people got a lot of symptomatic benefit from that higher flow oxygen. Something worth thinking about, if you're going to write standing orders at the time that a resident's COVID tests come back positive, it's important to order triggers that are going to get staff to contact you as the resident's status changes. So at the peak of the outbreak, Dr. Robert was writing the order set, including palliative care orders, if that was within the goals of care, at the time the test came back positive. So it's important to have a mechanism where you know who is changing quickly, so that you're aware of when things change quickly, because these personal care home residents with COVID-19 change extremely fast. So something that I thought might be helpful just to review today is, if this person was presenting maybe from the community to the hospital, what would acute care be doing? And then what things would be maybe not as feasible or appropriate in the personal care home? And what can we do? What's the difference between the care that we can expect or anticipate from acute care? So these are summarized for PMH in the COVID-19 suspect confirmed emergency department holding medical admission medication standing orders. And I'll just, I know it's sort of small, but on the right here is page 1. So they covered the oxygen and the acetaminophen. Now, Mr. M and Mr. G are known to be COVID positive, but with other people, or the very first symptomatic case, people who aren't tested when they're asymptomatic because of a contact, then the differential for their pneumonia or respiratory symptoms is broader. So there is a need to think about empiric antibiotics for Mr. M and Mr. G. The likelihood, given that they're COVID positive, for their presentation to be COVID is so high that perhaps there isn't a rationale for empiric antibiotics. In acute care, they will be using IV. In the personal care home, we would not. And the vast majority of the time, if we're talking about antibiotics, usually it's a trial of oral antibiotics in the personal care home to see if they respond. And even if it's a comfort care, goals of care, you can still talk about the option if there's the thought that it could improve a person's comfort, but recognizing the goals are more about comfort than extending life. And then we need to be thinking about, as we come into influenza season, as we're waiting for the nasopharyngeal swabs to come back, if they have influenza-like symptoms, then they'll get checked for influenza as well as COVID. But there is the need to think about antivirals until the swab comes back. There is, on the acute care, a thought about DVT prophylaxis. Now, if somebody in the personal care home setting is immobile enough from an acute illness or their chronic underlying conditions that they're at increased risk of DVT, then adding on the DVT prophylaxis is unlikely to change their outcomes. And this goes back to that conversation about they're so frail that they don't have the physiologic reserve to recover from the condition that's making them at increased risk. So most of the time, DVT prophylaxis would not be a part of your personal care home management and is a bit of a different strategy from acute care. On page 2 of the PMH, they have a nice summary of what the general goals of care of this order set would encompass. So it talks about oxygen, but it talks about a couple of other things that are more of an acute care priority. So going looking for metabolic derangement and organ failure than it would be in the PCH. And again, this is because if we go looking and find metabolic derangement that can't be supported by oral nutrition and hydration and maybe some gentle diuretics, then that may not be in keeping with the goals of care of remaining in PCH for supportive care and then palliative and comfort care. And of course, I'll just summarize here as we flip. This is part of the second page for the PMH. The infection control with droplet and contact precautions is the same, and involving your infection control practitioner. Establishing IV access is not part of the PCH plan. And what I would say is in the acute care standing orders, they have this check the boxes list of investigations. But we know what's causing Mr. M and Mr. G's presentation. So how is this additional blood work going to change their comfort or our management if the decision is made for them to be managed at the personal care home? So it is something that's important because our gut instinct, our long-standing practice is, well, we want the information, but what are we going to do with that information that'll change how we manage their situation other than sort of their clinical presentation? So I mentioned about having looked at these other order sets from across the country and some other things that I thought were good food for thought. We don't have an order set per se for personal care home, but some things to be considering is if it's within the goals of care to continue some vitals. Often they're described as being Q shift and as needed with meals. And that's again because of the attempts to decrease the traffic in and out of the rooms or the cohorted area of people with COVID-19. And if it requires some equipment, the need to clean all of that equipment. For people on oral hypoglycemics, the order sets comment on continuing blood glucose daily and as needed if they are different and you need to sort of reassess their sugars. And they actually comment that there seems to be an increased risk of hyperglycemia. So then they suggest consider the addition of a low dose basal insulin. Now, if somebody was more of a comfort and palliative goals of care, there also is the rationale in acute or the personal care home to not be doing the vitals and the blood glucose if it's not going to change their comfort. But this is more if we're still in that trial of a phase of active management in the PCH. I talked about the empiric antibiotics. In general, it seems that COVID-19 benefits from a restrictive fluid management strategy. So this is something they talk about in the ICU, but also in other active management. So if somebody clinically seems to have signs of dehydration, you could consider a trial of normal saline hypodermocolysis. And yes, that is available in our personal care homes. But again, really thinking about, okay, now they're hooked up to a line, and if it's not providing any symptomatic benefit, it's unlikely to change the course of the disease. So focusing on whether or not that's going to help them symptomatically. There is comment on the order sheets about holding the medications that are commonly found in sick day protocols when people are at risk of being dehydrated or not eating well. So that could be the case with people symptomatic for COVID-19. So with the oral hypoglycemics, there's the risk of hypoglycemia. And with the ACE inhibitors and ARBs, it's the risk of acute kidney injury if they're dehydrated, and NSAIDs often not appropriate for the frail older adults because of the risk of kidney injury, bleeding risk, and congestive heart failure. But if they're on these medications and not eating and drinking well, then it's probably important to reassess because we don't want to make things worse. So this is not a comment specific to some of the observations early on about ACEs and ARBs and outcomes. This is specific to people who are not eating and drinking well as part of a sick day protocol. There's across the country comments about reviewing the medications to decrease the frequency of medication passes. We're going to talk about that more next week. So back to our cases, both Mr. G and Mr. M are at extremely high risk of dying regardless of active or intensive medical management because they're both symptomatic now of COVID-19, and the ranges for people who are who are symptomatic and are older age. And now we're getting some evidence about frail is that you know, the mortality can be up at 50%. For these two cases, to move the conversation along, the goals of care during a serious illness conversation confirms the wishes for a supportive care focus on comfort or palliative care. So Mr. M is quietly in his bed. His oxygen saturations are very low, but he's not in any obvious respiratory distress. And this comment actually comes from a colleague of mine working in a COVID acute care unit. She's a geriatrician in Toronto, and she said it's actually remarkable how low some of their oxygen saturation is, but they're not in respiratory distress. So Mr. M is not eating or drinking any longer. So as far as the treatment strategy, he needs to be continued to be monitored for distress, and we need to be prepared to very quickly shift into dyspnea comfort care because people can change extremely quickly. They can go from asymptomatic to more symptomatic. But if he doesn't change into the more respiratory distress presentation, then he would benefit from more typical PCH palliative care. This is as opposed to Mr. G, who's dyspneic and has a panicked look in his eyes, and we need to immediately respond to dyspnea management to optimize his care. And his strategy would be summarized as managing dyspnea in progressive COVID-19 respiratory failure, receiving end-of-life supported care outside the intensive care unit. And I'm going to refer to a bunch of different documents to give you more information and run through some of what that may look like. So we're not inventing this right out of the blue. This set of recommendations is for goals of cares that are consistent with do not resuscitate, no ICU transfer, and comfort focused supportive care. And I'm grateful to say that Canada is not reinventing the wheel. Fraser Health was really early in developing some COVID specific advice and has been updating it regularly. And Shared Health has just put adapted the approach being suggested by Fraser Health and provided some additional support in a document called COVID-19 Palliative Care Guidelines. And this Manitoba version has been shared on virtual hospice in their COVID-19 resources, and that's a very well-respected resource across Canada for palliative care resources. So as I said, Fraser Health sort of had the first adaptation, or sorry, the first version of this, and called it Symptom Management for Adult Patients with COVID-19 Receiving End-of-Life Supportive Care Outside of the ICU. They update it, so the most reliable place to go is to the Palliative Care UBC site under their coronavirus resources. And this was then adapted again by the Ontario Palliative Care Network, and their version, I believe, came from McMaster University, and they are updating based on their experience. And unfortunately, Ontario, and in early days, BC had a lot of experience with this. Woo, that's loud. So this is another quiz. So I don't think you can hear me, but what dose of hydromorphone would you order? All right, I'm trying to adjust my volume. I don't know if that helps you or not, but that was supposed to be background. Maybe won't do that again. All right, next quiz question. So for residents on a scheduled opioid, how would you initially increase the opioid dose? And last one. Okay, so lessons learned from Mentimeter. That was jaunty music, entertaining if nothing else. So I know those were very black and white because they sort of said what was correct and what was incorrect, but now I'm going to provide some commentary about that. And hopefully for those of you who weren't using Mentimeter, you were at least able to compare your answers with both the group and with the what I said was the correct answer. So this is actually a picture of the summary, and So this is the Manitoba adaptation of the Fraser Health and the Ontario versions of this, managing dyspnea in progressive COVID-19 respiratory failure receiving end-of-life supportive care outside intensive care. And they all look very similar with the sort of opioids on the left. So if you've seen it, you've sort of seen it. And I liked that the Manitoba version had this fundamental concepts right up at the top. And I certainly agree with them. That progressive respiratory failure is a medical emergency, particularly because things can change so fast in the COVID-19 population. Opioids relieve respiratory distress in addition to treating pain and cough. Doses are individualized based on treatments and acceptable adverse effects. Rapidly evolving symptoms require titrating short-acting formulas. So that it really emphasizes that the short-acting preparations are the backbone of responding to the symptoms in a timely fashion. That opioids do not hasten death when given proportionate to the degree of distress. And that associated anxiety may benefit from benzodiazepine, and end-stage respiratory secretions are most asymptomatic for the dying person. So I'll just mention, this isn't specific to the personal care home setting, so we need to keep that in mind when looking at the things they recommend. Oh, no, wrong way. Okay. All right, so the other thing I like that was added to the Manitoba version is to perform and document a dyspnea assessment. So in these sort of sequential orders to increase the opioids, it really is important in the interdisciplinary progress notes or somewhere to be documenting the observations of why the doses were escalating. And so if the resident is able to participate, their reports of dyspnea, so not respiratory rate, but actually the experience of breathlessness and that air hunger. If they can, using a numerical rating scale, and then your clinical or the clinical assessment of the person who is there firsthand, seeing the symptoms that are trying to be treated. So in the various BC, Manitoba, and Ontario versions of this, Manitoba has suggested starting a scheduled opioid and PRN. Ontario only started with a PRN, and BC started with a PRN and then had a box warning against PRN, patient not receiving. And this is something certain where comfort and palliation is the priority, that if PRNs are not given, then they can't provide any benefit. So to answer our jaunty quiz question, there's a box specific to residents who are on a scheduled opioid to increase by 25% the scheduled dose and adjust their PRN by 10%. And when titrating up, to increase the scheduled and PRN by 50%. We'll talk a little bit more about the specifics of that. I just wanted to walk you through what all is contained in this summary. So when I look at this summary through a geriatrician's eyes, you know, all of our residents are frail. So anywhere through here that says, if frail, consider this. And they actually make a couple of specific comments about frail people. Take that into consideration. That's who we're talking about, is our personal care home residents. Renal dysfunction is common and underestimated in older adults overall. And the other thing is that we can't use the last time their creatinine was checked as a good estimate of how their current renal function is. And when people have COVID-19, they're going to be very high risk of being somewhat dehydrated and their kidney function not at risk. And for that reason, I would say the geriatrician in me would say that hydromorphone would be the safer choice for starting an opioid for dyspnea or pain. It has fewer active metabolites and is more predictably cleared. So start at half the dose is specifically in these summaries for those who are frail. And so that would be hydromorphone 0.25 to 0.5 orally, or half that for parenteral, so 0.125 to 0.25 for subcutaneous. And in the Manitoba version, they suggest starting a Q4 hours, but consider Q6 hours for the frail. So I would say that starting that scheduled Q6 with a Q1 PRN is a cautious but perhaps likely to actually treat some of the dyspnea they may be experiencing if they're symptomatic. So not before they're symptomatic, if they're symptomatic and developing some discomfort. The Manitoba version of this does not, in this summary, does not have the anticholinergic medications for secretions. The BC and Ontario do. And I think that's why they specifically say that end-stage respiratory secretions are mostly asymptomatic for the dying person. And it's emphasized in the British Columbia version as well, that they say it's, quotes, just noisy, which is hard for families and people who are providing the care. But the risk of adding the anticholinergics is that it could precipitate uncomfortable, distressing delirium, urinary retention, and constipation. So they're not completely benign medications. Also, the BC summary states in the sort of secretions is think about, are they actually wet? Would some furosemide help to decrease some of the rattle and some of their respiratory symptoms? So consider using furosemide. Also in the summaries are some other classes of drugs for other symptoms. So lorazepam is indicated for anxiety, not for any other symptoms. There is midazolam included on this one-page summary shared by Shared Health. And midazolam appears on the BC, Manitoba, and Ontario summaries. Remember, this summary is not specific to long-term care, and midazolam wears off very quickly. When I was talking to Dr. Robert, I sort of asked him about what I had heard from some other practitioners, that they just couldn't meet the needs of the dyspnea, the patients who were dyspneic from their COVID-19. And what he wondered were they using midazolam as part of their strategy, and was it wearing off too quickly? For the staffing available in personal care homes, a Q30-minute PRN is just not practical, whereas lorazepam, if it's being used for their anxiety, may be more practical. I'm going to skip down to the bottom bullet there. If the opioids just don't seem to be covering it, then methotrimeprazine is being suggested as an add-on, an adjunct for severe persistent dyspnea. Just coming up to the second last bullet there, for delirium, and I'm saying delirium, they call it agitation and restlessness, haloperidol and methotrimeprazine, so both of them antipsychotics, are given as suggested options for the agitation and restlessness that can occur. So let's compare that one-page summary to our PMH end-of-life order, standing orders. It starts off with catheterization, and I'm just going to, the geriatrician can't leave it alone, that if the person is continuing to pass urine and is not retaining urine, and you can provide for their peri-care, then catheterization comes with an increased risk of agitation, delirium, and also if there's period, they can injure themselves pulling it out. In this first page of the order set, they mention metoclopramide as an option for nausea and vomiting, and I'll mention that it can be associated with quite significant extrapyramidal side effects, so maybe haloperidol, again, in this end-of-life palliative care. Comfort management could be an option for nausea and vomiting. And they mentioned the respiratory secretions. You can use one of the anticholinergic, either glycopyrrolate and scopolamine. And I'll just mention that across the country, there are concerns about scopolamine supplies. So you may be told, well, we don't have that, but within PMH, we do have access to glycopyrrolate and atropine as alternatives to scopolamine. So on page 2 of the PMH end-of-life order set, it starts with anxiety management, and there could be an individualized order for lorazepam for severe anxiety. I would say that knowing how consistently it's emphasized that opioids are the starting point, there is the risk if you tick lorazepam that it will be used and not meet the resident's need. Whereas I think it is important to emphasize the degree to which, if they're in respiratory distress, the opioids are going to meet their needs more than lorazepam. And residents, so I'm going to move down to the opioids here. So important to remember that residents taking combination acetaminophen and codeine and acetaminophen and tramadol are not opioid naive. And codeine and tramadol will not be helpful medications to titrate to meet the needs of somebody symptomatic with COVID-19. There's no oral options for those medications. And one of the things I'd encourage is, if you're having to do one of these switches in somebody who's been using another opioid to hydromorphone, all of the PCHs are affiliated with a pharmacy, and whether it's a MediSystem consultant pharmacist or a PMH pharmacist, they do have 24-hour pharmacy support. And this is where I would be phoning a friend to say, can you help me with this switch over to a cautious starting dose, and then we'll monitor how they do, perhaps switching to hydromorphone. So they have a fill in the blank on page 2 of the order sets that could allow you to write one order for a PRN and one for a scheduled dose. So hydromorphone 0.5 orally, Q4 hours or Q6 hours, and Q1 hour PRN. You could fill in those blanks. If you want to order 2 routes, so PO and a subcutaneous, then you'd have to write the second order out separately. So that's our standing orders. The other pages of the PMH standing orders help with some titrating. So in those COVID summaries, as I mentioned, they recommend increasing the regularly scheduled and PRN doses by 50%. And they say the rate of titration depends on the patient's tolerance, so usually how drowsy they're becoming, and the severity of their dyspnea symptoms. And sort of waiting a day to titrate is likely not going to be frequent enough to meet their comfort needs. The other thing that's emphasized in the summaries is, if this is a time when they seem to be changing very rapidly, this is a time when you can call either your consultant pharmacist or the palliative care team to get some further advice about this. So another alternative to that titrating by 50% is the PMH standing orders have the steps that you could walk through right on those pages. And they have, as part of the standing orders, that if 3 or more PRNs are used within 24 hours, that's a time to go to the next step. Again, that might not be frequent enough for people who have COVID-19, but all of those summaries seem to say somewhere in the range of, if you're using 3 to 5 PRNs, then that's the time to go up to the next step. So PMH has a lot of other palliative care resources, and they're all contained in the PMH shared page. I know these are intranet, but if any of you want copies of them, either email Jocelyn at Nancy Stinton. We'll send you out a PDF version of these, but they've got pain management and then symptom management, which includes dyspnea, and then management of common concerns and symptoms. Those are PMH documents. And then on shared health, as I said, they've summarized everything into this palliative care guideline. It has the one-page summary that I've shown, but it also has some other information in the text. And I'll just highlight some of the things that they talk about as palliative care guidance, but that wouldn't work in the PCH setting. So if we look at it, you say, I can't do this in the PCH. So they talk about IV and continuous infusion medications. They won't be available in the PCH. Our PCHs will not have midazolam as ward stock. So it can still be ordered for individual patients, but it isn't something that at a moment's notice you're going to necessarily be able to use. And as I've said, lorazepam is an alternative for anxiety, methotrimeprazine being an alternative if the opioids aren't sufficient for the dyspnea. In some other summaries and some other webinars, there has been mention of phenobarbital. That also is not in our ward stock emergency stat kits. So I've heard much less about phenobarbital recently as people are getting more experience, but you can order it on a patient by patient basis, but it's not one that is going to be as readily available. The palliative care information talks about ketamine. That's more of an acute care that won't be available or safe at the PCH. And in this section, they talk about ondansetron injection for nausea and vomiting. And just something important to keep in mind that probably none of us would be aware is that ondansetron injection is not covered in the PCH setting and is very expensive compared to the contract we have for the acute care medications. I don't understand it, but that's the way it is. And I'd like to highlight also the resources available from Pallium Canada in their COVID-19 response. They've made these free of charge. They have online modules, including dyspnea, delirium, and pain, where you interact and test your knowledge. And they have webinars, and I'm sorry it got cut off, but they actually have one specific for long-term care. And as I mentioned, these are free to access through Pallium Canada. So just as far as our local preparations, are we ready? There was a list circulated in Ontario where you've heard their personal care homes are in quite a bit of crisis, whether they had the right drugs on site. We're supported very differently with our long-term care pharmacy and therapeutics, but the Alison Bell, the provincial PCH pharmacy manager, compared this Ontario list with what we have in our ward stock and emergency stat boxes. These are the drugs that are on hand at sites. So we don't have midazolam in PMH. We have an auto sub on the short-acting insulin. We don't have glucagon sites, kits for severe hypoglycemia. Instead, the intervention is to call EMS, and we don't have IV antibiotics and IV fluids. Another summary of what you should have on hand was in the CMAJ management of dyspnea, and again, aligned very well with the medications that are in our palliative care order set, which are also in our ward stock and emergency stat box. So as I just said, each personal care home has a supply of ward stock and emergency stat box, and it includes all the PMH palliative care standing order medications. MediSystem is managing drug supplies across the country, and they've been clear that they don't have enough supply to increase every single PCH to have their on-site enough medication for a major surge in cases. PMH and the province have been reviewing drug supply for acute and long-term care, making backup plans. So MediSystem has backup plans where they are going to have depots of extra drugs available 24 hours. In addition to that, for the MediSystem pharmacies, acute care is the MediSystem backup, and for the PCHs with PMH pharmacy support, the acute care is the backup plan, and there is a communication. There is ways to access that if there's a drug shortage. Also, there's been recently released the PMH initial outbreak response, which is sort of what the site will do as soon as they hear they have a staff or a resident who is positive. And in that is a discussion with pharmacy to make sure that there are sufficient medications on hand. So I really do think that people are thinking about the need to have enough medications. For our palliative care support, as I mentioned, the PMH information is available on the intranet site. And I just want to highlight that 24 hours, there's physician-to-physician consultation through St. Boniface Hospital, and you just call the number and ask for the palliative care physician on call. So this is maybe a number you can tuck away, but also it is available on the intranet site, this poster on the palliative care shared site. So here's our post-test. Thankfully, it doesn't have the jaunty music. So based on sort of what we've been talking about today, if you're on Mentimeter, I'd appreciate it if you could sort of fill in your thoughts about how helpful these classes of medications are for the different. And while you're filling that in, I am going to just read this comment here. So Joanne has mentioned the thoughts, but there has been discussion previous to COVID about IM medications and basically to decrease transfers and admissions. They've definitely been thinking about the IV fluids because of the need for training. Now, what I do need to clarify is what bags of solutions are available on site, because I've never asked that question. So I will follow up with you on asking that. But I agree, this is a time when if we can meet the needs on site and do it well, then that's an important consideration. So I'm going to take that one about what bags of fluid do we have for hypodermocolysis. Okay, there we go. Thank you very much for that. I'll follow up on that and pass that along. So just for our cases, Mr. M and Mr. G, Mr. M dies 7 days after his COVID test is positive. And for the last 2 days, he's unresponsive and in no obvious distress. He receives excellent mouth care, frequent repositioning, a few days without a bowel movement. His abdomen appears distended and he receives a PRN enema. Gets vigilant attention to pericare and frequent updates to the family, and he doesn't require and therefore does not receive a lot of comfort care medications. This is in contrast to Mr. G, who became symptomatic 4 days after his COVID test came back positive, and through the next 24 hours required frequent escalation on his opioid doses. He wore oxygen at some times, and sometimes he didn't tolerate it. He received some lorazepam PRN when he appeared anxious. He briefly developed agitation and was distressed or became delirious and received some methotrimeprazole with his opioids and settled well, and he died after less than 2 days of his COVID symptoms. So I'm going to sort of breeze here through the conclusions that we are planning within PMH how to provide for comfort of PCH residents symptomatic from COVID-19. And if the resident develops high acuity presentation or are severely frail and COVID positive and are quietly becoming frailer, they're at high risk of dying. And the medications listed in the PMH palliative care standing orders contain the medications being quoted across the country as providing symptom relief. So we have a little bit of time for questions. My half hour of discussion totally didn't work, but just too much information to provide, but we do have time for questions. And we have a response about the IM antibiotics from Alison Bell, the long-term care pharmacy, provincial pharmacy, about IM antibiotics being painful and erratic absorption in PCH residents. So the orals having good bioavailability if they're able to take them. Does anybody else want to unmute and ask any questions, provide any observations or things they've heard from other sources? And the other thing is I'd encourage you, if you have any feedback about things you want to talk about on the 24th, we do have the opportunity for either a sort of hodgepodge of question and answer or a specific topic. Get that feedback to me. I'm not seeing a whole bunch of people, so maybe, Jocelyn, we can stop the recording, and if anybody has any concerns in the PCH setting, I'd be happy to hear what's going on.